Good afternoon, everyone. Hi, I hope you're all feeling good today. My name is Michal Guindy. I'm a radiologist by training. I'm a breast imager, and I'm here as a representative of Agamon Health, a very interesting company that I want all of you to get to know. I met them as a radiologist using it myself, so I am a first-hand experienced person who is using the product and now is the medical director of the company. So pleased to meet you all. Happy you all here. I'm here to describe to you a solution for a very common problem I think every one of us knows, radiologist, but not always solves. And I think our company has a really great solution to find answers to some of the open questions that we have. So I'm going to describe to you two cases of patients that are real cases. And then I'll describe to you briefly how we try to solve them with our solution and give you some more information about the solution. And the goal of this meeting is for me to make you all want to come and know more about the way we solve the issue, which is a very common issue to all of us. So our first patient that I'm going to present is John. He is 52. He went to the operation room because of a car accident and had an abdominal CT done to him. And in the CT, as an incidental finding, there was a lesion, not so big, not so small, 6 millimeters. And this was seen by the radiologist, and he recommended within 3 months, follow-up of a full lung scan to this patient. Unfortunately, this recommendation was not included in the discharge letter, and so the patient did not have the CT done to him. And 8 months later, he had another CT done for other reasons, for stomach ache. Again, the lesion was seen, and this time the size of the lesion was slightly larger. It was about 8 millimeters, and obviously something was missed here. So this situation is actually not very unusual. We know from the literature that about 40% of all recommendations that are given in the operation department are not being followed. And of those, we know that 22.5% of recommendations are actually considered to be critical recommendation, and still they're not included in the discharge letters. On our data from our customers, we know that close to 40% of the recommendations that are being given in the EU are not actually happening. So that is not exactly the same, but it still is the same ballpark numbers of people that need to have things done to them that are not being done. So here is another story. This time we are talking about a lung cancer screening program. This lady enrolled in a lung cancer screening program, had her initial study done. There was a very small nodule, 4 millimeters, found in the study. And of course, the recommendation was to do a yearly study, which is the right one. Only the lady didn't do it. She only came 2 years later. And at that time, the nodule was 8 millimeter in size. Again, there is a good chance that there is a delay in diagnosis for this woman who could have come a year before but didn't. So again, this is not an unusual case. In fact, in lung cancer screening, the data that we have, when we look at the people that are coming back without Agamon interference, without our interference, not coming back, we see that even in cases where the recommendation was to come back in 3 months, so something was really quite unsettling, should we say, only 43% of the patient came back. And in the cases where the follow-up was recommended to be within a year, only 20% of patients came initially back without any assistance of our system. So the numbers are really low. And also in the literature, actually the range is really quite alarming. You don't know what to make of it. Some studies say that only 12% adherence, and some studies describe a much higher adherence of 91%. And we do know that there are factors that affect the adherence, whether it's coming from a rural area or a urban area, patient's characteristics, so various patient's characteristics, and system characteristics. So some places have a more tight system and others have a less tight system. And I always say that there is a contract that needs to be taken between the patient and when he enters a lung cancer screening program, because it is a program, it's not a study. It's not a case where you do one study and you're done. You need to be part of a program, and you need to know from the beginning that you will be coming every year in order to do the lung cancer screening, much like what we have in breast, but unfortunately is not that common in lung cancer screening. So how does Agamon address this issue? So first, we look and we try to see what is going wrong when this doesn't happen. When people are not coming back for the recommendation, why would that happen? And we know that the longer period it is between the day that the patient has done the initial study and the time he needs to come back, the more chance it is that he will not come back and he will not do the follow-up. We also know that a lot of time the recommendation that we have written as radiologists was not clear enough, and it might not be clear enough in wording or in time frame or in various other ways, and that causes the patients not to come back, or causes also the doctor not to refer the patient for a second study. There's also a lot of time an issue of just not having any communication between the radiology department and the referring physician, and this is a real issue for a lot of centers that are really trying to build a relationship between the referring physician and the clinic, and you want that they would see you as a part of their system, and that doesn't always happen. And we know, and there's a study that just reported that close to 7.5% of cases, the letter of recommendation reaches the clinician, but he doesn't open it. So if he doesn't open it and he doesn't read it, obviously he doesn't know that he needs to send the patient for another study. The same research actually showed how often the clinician looks at the images, and that's also a lot lower, but that's expected, and not all clinicians know to look at images, and I don't think it's as serious as just not looking at the result at all. And that might actually cause a lot of issues with compliance. So how do we try to solve it? So we understand there's a problem. We know that this problem is actually causing harm. And the question is, how can we actually address this problem and solve it? And our solution is actually quite diverse, but I'm starting with showing you the robust, fully automated solution, which is basically doesn't demand from you to do anything, just to allow the platform to live on your data so that you could look at the data, the platform could look at the data and take out the recommendation and do something about it. So the way we work is the following. After the radiologist has finished writing his report and has signed it, so we're not interfering at all with the way the radiology is writing his report. He doesn't need to flag anything. He doesn't need to do anything different to the way he does it now. The AI is reading the report and deciding on, after reading the whole report, not only the recommendation part, but also the top part, he decides whether there is a need to do something, to do any kind of follow-up after the study. Once he's done that, once the AI has decided that, then we make a ticket for every recommendation. And that recommendation can run in an automatic fashion, it can run in a half semi-automatic fashion, or it could be fully manual, going to the care coordinator that is already existing in some of the centers we work with. And then after we refer it to them, we have a triage system that is actually hosting most of the sense that the organization has. So, for example, some places would say, when you have a recommendation that says clinical correlation, we don't want to be follow that. This is something we cannot follow and disregard it. Or when there is a need for a conditional recommendation, so if symptoms persist or something like that, we don't want to be follow that as well. We also don't want to be following a situation where the recommendation is to repeat just a plain x-ray. We just want to be repeating CT scans or MRI scan. We don't want to do mammography. We only want to do mammography. All of those options, all of this brain is sitting in the triage area. And then after we focus on that, what comes out is a recommendation that needs to be directed to one of 3 or 4 options, either to the referring physician, or sometimes when it is an incidental finding and the referring physician may have been an orthoped, and now the finding is to do with his kidney, so it's not relevant to him. We want it to be referred to the PCP, or it could be directed to the patient itself, or in some centers we have referral to specific specialists. So they want all the incidental lung nodules to go to the pulmonologist, and we do that. So it really does depend on the choice that every center has. We also spend time looking whether there is actually already an order placed in the system, because if there is one, we don't want to be disturbing people unnecessarily. We don't want to have alert fatigue. And we obviously look also to see whether the study was already scheduled, because some people come back normally and we don't need to disturb them with our reminders because they're already on the way anyhow. Okay. So our data shows that even with using a fully automated system, which means that no human interference, just looking at the system, finding the recommendation, directing it according to the flow that is decided with us and the company, we already increased the adherence rate with LCIS to in 117%. This is like doubling the amount of people that came back for just regular LCLS program. And in incidental finding, the same group that we looked at the data in has 55% increase just with fully automated system. Obviously, using nurse navigators in several cases could even make the percentage higher, and it does affect. The platform is actually much more versatile than what I've described to you, because what it can do is actually can get data from various sources. So beginning with the medical report, going through the EMR, going through a third-party database, going through questionnaires that you have the patient fill when they come in. So a lot of places have a questionnaire for the patients to fill before they come and do several procedures. We go through all of this. We take all of this into consideration. And then once we've done that, we've read all that, then we could come up with various solutions. So the classical one that I just showed you is just sending reminders to the patient's physician or PCP or to the patient itself. But we could also, and we do, compare whatever has been recommended with guidelines. And we could flag situation where, for example, the guidelines say differently than what the doctor recommended. And then we could flag it to the nurse navigator or to the head of the department or whoever wants. And then he could check and see whether he wants to change the recommendation or whether he wants to speak with this specific doctor about the recommendation and whatever is necessary to do. There's also an option of identifying patients that are suitable for doing various kinds of procedures. So we could identify patients, women patients that are doing breast cancer screening and that are actually in a high risk population, and say, let's call all of those women to do an MRI because they have high risk situation that allows them, that qualifies them to have an MRI follow-up. We could also build special cohorts for doctors for specific interests. So if, let's say, there's a new procedure that this center is doing and they want to, when they plan it, realize how many of this procedure is relevant for them, we could look at the data and come up and give the details to whoever needs to plan it. And also we could generate this list ongoingly so that we could tap on those people and communicate to their doctor or to them, depends on what it is, that they are eligible for a procedure that we could do for them. And we've been doing this with one of our centers. So what we're doing right now with all of the customers that we have here in the US is lung cancer screening, high-risk breast cancer screening, as I described, with women needing to do MRI, prostate screening, colonoscopy, cardiac screening, and analytics. So we could give the management a picture of who is working how and what isn't working and what is working well regarding our referring physicians and regarding our own staff that is working with us. That is it. I hope I made you curious, and I hope all of you come over to our booth and get more information about the solutions. I didn't describe to you a lot of details that are really critical, and you know God is in the details. So come over, present your own situation and case, and I hope we find a way to help you close the gap. Because I think as radiologists, doing the study and not having it being followed is very frustrating. As a mammographer specifically, I think this is the most annoying thing. If you see something that you've already traced in the previous study and you said something needed to be done and it's not being followed, and you see it in a worse condition, it really is a shame, because we did the study, the patient was there, we did write the recommendation, and then in the end, he's not doing what could have saved his life. So let's all try and do it better. Thank you.